So are we just gonna move on to like assuming that it's pneumonia and just talk about it after? Or are we?
No, we're gonna go through the actual case itself, and we're gonna try to figure out why is it pneumonia, why is it not other things. There are different things inside the case, and you'll see that can lead you to another diagnosis, but we'll go from there. Cool? Okay, let's get started. So we have a 78-year-old female with progressive chest pain and shortness of breath over the last 1 to 2 weeks. She's alert and oriented to herself and to where to the date, but not to the place or the situation. Her daughter is present to help you out with some of the history. So 2 weeks ago, she felt ill. She had a sore throat. She had congestion. She had a slight cough. So Dr. Sophia, why is it important to know that she had these symptoms prior? What is that indicative of? Dr. Sophia?
Oh, sorry, I couldn't turn my microphone on.
That's okay.
So I think because it's pneumonia, that usually happens after a sickness. So knowing that she had already been ill would probably clue you into that, especially the cough.
Yeah, so if it was pneumonia, the cough can definitely clue you into that. But she has a sore throat and congestion. So does that mean she has a pneumonia at that time?
No, at that time, I don't think that would necessarily mean that, especially the sore throat, because that's more upper respiratory as opposed to in the lungs.
Good. So we're saying that upper respiratory is going to be kind of ear, nose, throat. Lower respiratory is going to be more of the lungs. And a lot of times you're going to have the upper respiratory infection progress into a pneumonia. So perfect. And so we know that she had some type of viral illness prior to the onset of her symptoms. So any cardiac issues that could cause.
Wait, sorry, you're asking me again?
Yeah. So is there anything in the heart? So if she had a preceding viral infection, is there something that can cause with the heart?
Couldn't that cause inflammation in the heart as well?
Where?
The pericardium.
Perfect. So what is that called?
Pericarditis.
Pericarditis. Perfect. So a lot of times with pericarditis, you'll have a preceding infection, like a viral infection, and you'll have subsequent inflammation of the pericardium. So is there anything else that you can think of that can cause pericarditis other than infection?
Other than a bacterial infection, I think you had mentioned before that cancer or other autoimmune disorders could cause it.
Perfect. Yeah. So autoimmune disorders, cancer can do it. Sarcoidosis can do it. So good. All right. So her symptoms improved overall, but her cough lingered. She felt weak and started complaining of chest discomfort. She would normally walk around the block with her dog, but now she doesn't want to. So Dr. Schultz, if I told you that she doesn't want to because she's short of breath, what would you be thinking of?
Can you repeat the question?
So if I told you that she doesn't want to walk anymore because she gets short of breath when she walks, what would you be thinking of?
I would be thinking that it's probably like a lung problem if it's shortness of breath. Since it is like pretty like it's like an easy kind of exercise, it's just walking. I wouldn't think really of a heart problem.
Okay. A lot of times with patients that have heart issues, even with walking, they can sometimes have pain in the chest, but it's usually pain and not so much shortness of breath. You can have shortness of breath, and that can be indicative of a heart attack, but not always. So yes, I agree. Is there any specific, you said a lung issue, is there any specific lung issue that you're thinking of?
Whenever I read through it, I was thinking of either pneumothorax or pneumonia.
Okay, pneumothorax for sure. Pneumothorax would traditionally, though, be more acute onset and not so much slower, as her picture looks like. Pneumonia also can cause some shortness of breath, but it's not very typical to cause it only when you're exercising. You would mostly have some shortness of breath. If you're having shortness of breath, you would have some baseline as well. Not always, I guess, but yeah. So what about anything with the heart that would specifically cause shortness of breath and not chest pain per se?
Would it be a pulmonary embolism?
Pulmonary embolism is a good thought, but that would also cause chest pain. This is a hard question.
Maybe an angina?
Angina would be more be chest pain as well. What about Dr. Natoli? What would cause a heart issue that would cause specifically shortness of breath and not necessarily chest pain?
I was thinking it could have been maybe her history of coronary artery disease, maybe.
Yeah. So coronary artery disease can cause, it's going to put her at higher risk of having a heart attack. So, if we're talking about shortness of breath specifically and not chest pain, a heart attack, so an MI or an angina would be less likely because those typically will cause pain. Now, in older adults and in women, you're going to have atypical symptoms with chest pain. But a lot of times they'll still have some sort of pain or discomfort, either in the chest, in the neck, in their arm, in the belly. But they'll have that classic. They feel that pain when they're walking or they're exercising, and then it gets better with rest. But other than angina or an MI, anything with the heart they can think of that can cause shortness of breath, not so much chest pain. And it's okay if you don't know.
Heart failure? I'm not sure.
Yeah. Perfect. Heart failure, congestive heart failure. So with congestive heart failure, it's a failure of the pump itself. So the heart is not able to push fluid forward either because the heart muscle itself is very weak and dilated, or because the heart muscle is too thick now because it's been having to pump against a lot of resistance. And so that if you have either of those situations, you will have a decreased ability to push fluid out. And so that fluid's going to back up, and it's going to back up into the lungs. And so as it backs up into the lungs, you're not filling up your lungs full of fluid. You can't adequately exchange oxygen if there's fluid in the lungs. And so because of that, you feel short of breath, but you don't necessarily feel chest pain. If it gets bad enough to the point where you're now not able to oxygenate very well and you can't get oxygen to your heart, well, now it's going to cause chest pain. Does that make sense?
Yeah.
Okay. So I mentioned that she doesn't. She had felt sleepy recently, sorry, I mentioned that she was up 6 days ago, and she was confused. Why is that important, Dr. Khan? Why is it important that we're saying that her daughter is saying that she's confused?
Oh, sorry. I couldn't get my microphone on.
It's okay.
I remember you mentioning this in your most recent video, but I can't remember exactly what you said. I think it's important that she's aware of her surroundings, but I don't remember exactly why.
So she has a history of dementia, right? So we know she has baseline decreased cognition or mental status. So, but her daughter says later on, she says that she's able to do most of her daily activities by herself. And her daughter is mentioning she looks more confused now. So it's important for patients that come in with dementia because being able to distinguish, is this her dementia and that's why she's confused, or is this something new on top of her dementia that's causing her to be more confused? It's important to distinguish because that helps dictate whether or not we need to admit her and to see if there's something else going on other than her baseline dementia. So it's a clue to tell us that there's something more going on with her.
Okay, that makes sense.
Yeah. So I also later on I say that she as she continued to cough, her chest pain worsened. So Dr. Khan, what can cause worsening chest pain with cough?
Is it if the lungs have a sac of, or not a sac, but like when the lungs are like inflamed and there's like an area where the air can't get through, like when you were talking about the vacuum not being able to suck in the air?
Yeah, so like a pneumothorax will cause pain
Yeah.
with that if there's inflammation in the pleura. But I think the pleural inflammation is more pertinent because a lot of things can inflame that lining of the lung. And so when things inflame that lining of the lung, even when you breathe, you can have some pain, or when you cough, you're going to have some pain. Other than inside the cavity, what about in the general thorax? Is there anything else that can give you chest pain like that?
Maybe like a clot.
A clot can, so if it's a pulmonary embolism, you can get some chest pain. Dr. Schultz is helping you out in the actually pericardial. She's saying pericardial inflammation. So pericardial inflammation can cause chest pain like that. But what about what other than inside the thorax? Anything outside the thorax cause pain?
I see some of the other members. They're saying like muscles or like ribs.
Yeah. So as you're coughing more, you can have inflammation of the ribs as they attach into the sternum, and so that's called costochondritis. And so that inflammation, because you're overworking those muscles and those structures, will cause pain, especially when you're coughing. And so that's a non-cardiac cause of chest pain that you should be familiar with in the future, because a lot of patients will come in with chest pain saying, I think it's my heart, but in reality, it's more so just the muscles and the cartilage. So good. All right. So the daughter is saying that she's refusing to eat. So Dr. Varsha, why is that important? Let's go with Dr. Cheng. Why is that important that she's refusing to eat?
I'm so sorry. Did you say, was that my first name? I'm not sure.
Oh, I said Dr. Varsha, but we can go with you. So, Dr.
Sorry.
It's okay. So why is it important that she doesn't want to eat?
Oh, are you going with me?
You. Yeah.
Okay. I think she's refusing to eat because I feel like it could be the symptoms of her pneumonia. Maybe her medication is probably like taking a toll on her, and as mentioned in the case, they do say that she's lethargic, so she's probably like not motivated, or I feel like when you're sick in general, you just don't have the motivation to eat, so that could probably be a reason.
Yeah. So it's a change in her baseline is what is most important. And you're exactly right. When patients are really sick, they don't want to eat. They don't want to do a lot of what they typically would want to do. And so it's important to get that history too, to kind of triage and say, this patient is actually sick, they need to be in the hospital, versus, yeah, they're eating, drinking okay, everything looks okay, they can go home. So good. Now, Dr. Cheng, so I say that she denies chills, nausea, vomiting, abdominal pain, hemoptysis, loss of consciousness, palpitations, and anosmia. Any of those stick out to you?
I feel like hemoptysis stuck out to me because it's like coughing up blood, and I know that may relate to like infections such as tuberculosis, bronchitis, pneumonia, or like
Yeah, so hemoptysis can happen in all of those. What is something potentially? You said tuberculosis. Other than tuberculosis, that is very can be potentially dangerous. What else is something that can cause hemoptysis?
like cancer.
Cancer, perfect. Yeah, lung cancer. So, why does lung cancer cause hemoptysis?
Is it like the inflammation of the lungs somewhere?
You can have some inflammation around the lungs, but what does cancer do? So why is cancer so dangerous?
It's like a buildup of cells, and so like I guess like it ruptures somehow.
Yeah, so cancer is an uncontrolled growth of tissue. So you'll have cells dividing uncontrollably, and so as it divides, in order to divide pretty much infinitely, it needs nutrients. So it'll sometimes recruit blood vessels to the cancer itself, and if that gets out of control, you can start bleeding into the cancer. And so that's one mechanism. The other is if you're disrupting the vessels around that cancer, because it's growing so aggressively, you can start bleeding into the airways, and the blood is an irritant, and so you'll start coughing that up. And so a lot of times for lung cancer, that's the first sign of a lung cancer. You have this chronic cough, and you start coughing up blood, and you get an X-ray, and it looks like there's a mass there, and it turns out to be cancer. So very good. Okay, so there's a few questions here. Inflammation is caused by an immune response. Yeah, so inflammation in general is caused by our body's response to an infection or some other immune process. So abnormal decrease in appetite due to dementia, I guess that's what they're asking. So yes. And okay, perfect. And so Dr. Cheetos, Lucy Cheetos, anything else stick out to you for the ROS? Let's go with Dr. Fisher.
Were you saying anything else sticks out with the like list?
The review of systems, yeah.
The loss of consciousness kind of stuck out to me in the palpitations.
Okay, why is that?
I don't know. I was just kind of thinking the loss of consciousness. I was like, well, that's like not normal.
Yeah. So okay, I think there was a little bit of confusion because I misspelled denies. So she denies all of those. So I apologize. I apologize for that. But it's good to know that she hasn't lost consciousness, because if you were to have something like a seizure, well, you lose consciousness if you have a full-on like grand mal seizure. So that's important to know. And palpitations also, a lot of times you'll feel palpitations when you have an arrhythmia. So when your heart's not beating regularly. So that's also important to know. Someone on YouTube is asking about anosmia. So what do you know about anosmia?
Not really much.
Okay, that's okay. So anosmia is the inability, so the lack of smell. So you lose your sense of smell. So what's going on right now that can give you loss of smell?
Corona.
Yeah, exactly. So COVID is something that's going on that could potentially cause a lot of different symptoms. We haven't classified it very well. All the patients that I've seen with anosmia have had COVID. So it's a really important thing to ask, especially right now, and especially if you're out there working as a scribe or as an EMT, consider asking them that. And if they say yes, protect yourself and protect the people you work with. So good. Now we'll stay with you. She lives at home with her daughter and son-in-law, and the son-in-law is working at his office, and he's required to go to work. So what are some things that you would consider because of that?
If he possibly comes into contact with someone who's had COVID and then is contacting with her, especially with her old age and her history, she can catch COVID pretty easily. It could be pretty damaging to her.
Yeah, and exactly. So the other thing is that her daughter and son-in-law are both working. So if she's at home a lot of the time, and if she's by herself, well, she might fall, she might hit her head, and nobody would see that. I mean, her 2 grandchildren are there, but we don't know how old they are. The other thing is that if she's in charge of her own medications, how reliable is she when she is confused, right? So if she takes too much of her medications, she can overdose on some of her meds. And what would be one of her medications that is potentially dangerous to overdose on? Dr. Dupuy. I hope I pronounced that right, by the way.
Oh, you pronounced it correctly. Thank you.
Yes.
So I, in my research of this, only really investigated possible side effects of the medications that she's on. I'm not quite sure of which are potentially dangerous for overdose.
Good. So, which ones did you come across that might cause confusion?
I'm not quite sure because I really only flagged ones that were relevant to the like cough and upper respiratory consistencies.
Good. So which one did you which one did you flag?
Well, for Linisopril, that one was very common for cough and chest pain and fatigue, which was very consistent with her symptoms.
Yeah, so that's actually a really good point that I didn't really think of until you just said it right now. Lisinopril famously causes a lot of cough. So if this was new and she started to have a cough after that, then that is something that we can say, yeah, maybe it's the lisinopril. If she didn't have any of the other symptoms, of course, but yeah, it's a really good point. The glipizide is a diabetic medication, and so glipizide decreases your blood sugar, which is important for people with diabetes because their blood sugar is high. So if she takes too much of it, what could happen?
She could possibly be experiencing confusion due to low blood sugar due to overdose of the medication.
Perfect. Yeah. So, and glipizide lasts for a very long time. I believe you can dose it once a day, and it can work pretty much all day. So if you take like 2 or 3 pills or 2 or 3 times more than you're supposed to, well, you can have low blood sugar for a very long time. I had a kid, it was a young kid at one of the pediatric hospitals that accidentally got into family's medication and took a bunch of glipizide and ended up having seizures for a very long time because they could not control his blood sugar because it kept dipping down. So glipizide is a potentially dangerous medication if you take too much of it. So good job. Dr. Let's say Dr. Fitz or Anna. Is it FLTS, Dr. Phillips?
Yeah, FLTS. It's pronounced Flitz, but you're good.
Okay, that's cool. All right, so can you interpret her vitals for me? So her blood pressure is 158/93, her heart rate's 110, respiratory rate's 24, temp is 100.5, and O2 sat is 93% on room air. So what sticks out to you?
Okay, so I would say her blood pressure, that's pretty high, but I think we knew that already. So I don't know if she's taking her medication or not for that. That would be something to consider.
Mm-hmm.
Her heart rate is also pretty high, which also makes sense because of the chest pain. Respiratory rate also pretty high, as well as the temperature.
Okay.
And the O2 stat is on the lower side.
Good. So is there anything with those vitals that you would think of? Let's say you're considering an infection. Is there anything that you would think of that, like a syndrome that she might have because of these vitals? And it's a harder question.
Yeah, I believe it's called SIRS, if that's how you pronounce it.
Yeah, so what is that?
It's an inflammatory response, like a systematic inflammatory response.
Okay, and so what is your criteria for SIRS?
I believe it was 2 out of the 4, either heart rate, temperature, respiratory rate, or the white blood cell count.
Yeah, and so if the temp is elevated, if the heart rate is elevated, the respiratory rate is elevated, and the white blood cell count is elevated, those are all criteria for SIRS. And so let's say she has SIRS and you can't find a source. Can you call it sepsis?
No.
No. So you have to have a source to call it sepsis. So SIRS is a system-wide response to some sort of insult. So if you have an infection and your body's trying to take care of it, it can cause system-wide inflammation. And a lot of times it causes your vessels to dilate. It can decrease your blood pressure, makes your heart work a bit faster. You can start breathing a bit faster. And then you have signs of inflammation through your white blood cell count. So it's important to note because that will help dictate whether or not this patient needs to stay in the hospital or they can go home. So, so perfect. So Dr. Sai, if this patient had normal vital signs, would you classify her as SIRS?
Probably not, because the whole point, or like the whole reason that we would diagnose SIRS is because of the vital signs, like the normal vital signs: high temperature, high blood pressure, high respiratory rate, and high white blood cell count.
Good. And so would she be able to go home?
Given the rest of her symptoms, I would not want to send her home, but wouldn't we be allowed to if she didn't want to?
So if she really wanted to go home, and her daughter wants her to go home, we can't keep her there. Yeah, so most of the time, if she looks really bad and the vitals look okay, I would probably still keep her because elderly patients can crump pretty fast. They can decline pretty fast. So, but it all depends on how they look. But the vitals are very helpful to decide whether or not they can go home or not. Somebody asked, does SIRS have an incubation period? So SIRS isn't necessarily a infection. It's the response your body has to some sort of insult. So an infection, autoimmune process, something like that. So there's not a specific incubation period for that. So I hope that answers your question. Okay. So Dr. Mina, anything stand out to you in the physical exam?
I guess my biggest concern was, let's see. I was concerned about the fact that, well, like I thought that her cough was obviously indicative of maybe something viral that, like, dropped down to her lungs.
Okay, so let's talk about the lung.
Lack of blood in her cough or her non-productive.
So within the lungs, so in the respiratory exam, was there anything that stuck out to you as potentially problematic?
The crackling in her lungs.
Okay, so what does that tell you?
Well, I think looking at that and then also her chest x-ray, if there were some sort of like buildup, either fluid or an infection, then that can explain why you were crackling.
Okay, so so with crackles, you're right. So you get crackles because the alveoli, that end part of the lung, that little sac of what looks like grapes, is where the gas exchange happens between the lungs and the blood. So if you have fluid within those sacs and you start to inflate, it sounds like you have this crackling type sound that kind of sounds like Rice Krispies. So it's that fluid in there. It can be fluid, it can be pus, it can be really anything that causes that sound. And so having those crackles in that area tells us that there is something there. If you had, is there any other way to tell if there's something in the lungs that on physical exam that is not supposed to be there?
I think if you were to, like, I know tapping against the chest, if you were to hear like a dullness in the chest, that can be indicative of like a infection from the inside.
Good. What about agophy? Do you know what that is?
No, I don't know what that is.
Okay. So.
Oh wait, yeah, I think I. When the patient says E and then it sounds like A
And why does that happen?
because of how the sound. I'm not too sure why.
Okay, I think you almost had it. So the way that sound waves are propagated through different materials can determine how it sounds to us when we're listening to it. So if you are saying something through air, it's going to sound one way, versus if you try to say through speak through a more solid interface, it's going to sound a little bit different. So the when we're listening to the person without our stethoscope, it sounds like E because the sound is propagating through air. When we listen to it, it now has to go through this more consolidated area that is potentially infected, so it'll sound like an A. And that's all dependent on how the what frequency is not so much filtered out, but like gets to your ear. So that's why you have that change in sound. And so it is helpful if you do the E to A sounds. If you hear something there, you're going to probably want to get a chest X-ray to make sure that there's nothing in that area. So good. That was really good. All right. So Dr. Perry, so in the ear, nose, and throat exam, anything stick out to you?
Hello?
Hey.
So I would say the fact that there's no tonsillar swelling.
Uh-huh.
Because I think it eliminates some of like what kind of infection it would be.
Yeah.
The tacky mucous membranes as well, because I feel like that would be indicative of like the pneumonia potentially.
Why the pneumonia?
Because I think that pneumonia has to do with like the cilia doesn't clear like your airways properly, and so I think if you had a lot of mucus buildup, you'd probably that would be because it's not getting cleared out.
Okay, so tacky mucous membranes refers more to like the mouth itself. So the mucous membranes tend to be a little bit dry. So when they say tacky, it means more kind of like sticky almost, but not really sticky. So like if you ever had a dry mouth, that's what tacky mucous membranes look like. So it means more like that there's signs of dehydration.
Oh, okay.
Yeah, so the other way to tell if a patient's dehydrated, so one is you look in the mouth to see if it's dry or not. The other one is you pinch the skin, and if the skin drops normally, so I don't know if you guys can see it, but like my skin, as I let go, it drops and goes back to where it is. But if it stays tented up like that, a lot of times that means that a person is low on fluids, and so it'll stay kind of like a tent. So yeah. All right. So Dr. Trivedi, if we're saying that she might look dry, is there anything in her labs that can point to her being more dehydrated?
Yeah, the sodium values can determine if she's dehydrated. Right now it's at a 133, which would indicate dehydration.
Okay, yeah, it can. Low sodium can cause dehydration. A lot of times, even when patients aren't really dehydrated, the sodium can be a little low, and that's okay. But yeah, definitely that can be a sign of dehydration. What else?
Just like going along with the sodium, the potassium, but also maybe the BUN and creatinine, since it's involving kidney regulation and could like involve a kidney injury.
Exactly. So her baseline creatinine is 1.1, and she has a history of chronic kidney disease. So what does the 1.8 mean? Do you even care? Because she has a elevated creatinine at baseline. So does it really matter if her creatinine is elevated?
Yeah, I think it does, just because it's like way higher than the baseline.
Exactly.
Yeah.
Yeah. So it's higher than the baseline. So patients with a history of chronic kidney disease are going to have an elevated creatinine normally. So you have to be able to distinguish, is this creatinine normal for the patient or is it more elevated? And so if the creatinine is more elevated, what can cause that?
It could be like chronic or acute kidney injury.
Okay, so what would be a cause of acute kidney injury?
Acute. Well, there could be like 3. So like loss of fluid or like not enough fluid. Like kidney failure or like blockage, like lower down that like causes a backup of fluid to the kidneys.
Yes, exactly. So if you can't drain from the kidney, if you like, let's say you have a kidney stone that's stuck inside the ureters and you're not able to drain that out, you're going to have kidney injury. The other thing that happens a lot is with contrast. So when you put IV contrast in when you're doing SCT, the contrast helps light up the vessels a bit more, but it can also damage the kidney. So you can have kidney injury because of that, and that's more of an intrinsic kidney damage. So that's intrinsic to the actual kidney itself, not so much the fluid coming in or the blockage afterwards. So so those are the 3 types. Either not enough fluid getting to it, so that's pre-renal. Intrinsic renal, meaning there's something wrong with the kidney itself because of some type of damage from a medication or a contrast, or post-renal, meaning after the kidney, there's a blockage somewhere. So a lot of times it's a kidney stone. Sometimes for men, if their prostate enlarges, the ureters drain into the bladder, and then the bladder goes out and past the prostate. And so if the prostate's enlarged, it can clamp down on the urethra and cause an obstruction there. So those are some of the different causes of kidney injury. So very good. All right. So Dr. Kimani, can you interpret that troponin for me?
The troponin is slightly elevated. I don't think it's so high that it would indicate like pure damage to the heart because she does have previous heart injuries. I would say that a pure damage to the heart would seem a lot higher. So I think it's more so the infection that's kind of inflaming the heart or hurting the heart in some way, more so than it being purely a heart injury.
Good. So what if I tell you that she now has chest pain that occurred after she was walking, and she has a troponin of 0.07? How would that change your management?
Then I'd be more worried about the heart, because if it's more purely chest pain, that could be related to like angina or other problems within the heart specifically. So I'd be more concerned about whether her troponin levels are increasing because there's more damage occurring to the heart over time.
Yeah, but her troponin is 0.07, so it's not super high. So why would you care now versus before?
Because it's pain to the heart as opposed to the shortness of breath. So if it's like pure pain to the heart itself, then that, or like chest pain specifically, that might be related to like tears in the heart or other heart problems.
So I kind of missed a little bit about what you said because I think my audio cut out, but it's all dependent on what your suspicion is for the cardiac chest pain. So it's your pre-test probability. So before we even test this person, what are the risk factors that would make her have a heart attack be more likely versus something else? And so for her, she has a history of coronary artery disease. She has 2 stents already, so we know those vessels are already damaged, so to say. Dr. Natoli says that her dad had a history of a heart attack, which is very true, but so that can also increase her risk. But with her father's history of the heart attack, he had the heart attack at the age of 81. A lot of times we take into consideration more like as a risk factor when the heart attack is at an earlier age. But you should always, if anybody has a heart attack in their family, you should always keep that in your mind too. So that was a good pickup, Dr. Natoli. So we have to determine what her pretest probability is. For her, with the scenario that I gave you, do her symptoms sound like a cardiac issue?
No, I wouldn't associate it with a cardiac issue because a lot of her vitals, and also you didn't hear anything on the I guess we haven't really gotten to the EKG, but like we didn't see anything on the EKG that would indicate like ST elevations or something like that, indicating a heart attack. So I would associate it more with a lung issue.
Okay, and so if we change our history to have more of that exertional chest pain that gets better with rest, that's more consistent with a heart issue, right?
Yeah.
So our troponin of 0.07 has more value and has more meaning when you're considering something with a cardiac picture. So if the troponin was 0.07 and she was having a cardiac picture, and she eventually, you get an EKG and it shows ST segment elevations. Why is that troponin so low? Or why is that on the lower end? Why is it just mildly elevated is what I'm trying to ask.
If you have ST elevations and your troponin is only mildly elevated, like it's only at a 0.7 as opposed to like something higher, then the ST elevations could be caused by something else as opposed to like a heart attack or an MI, because like I would expect it to be a lot higher if she was actively having a heart attack. You'd expect the troponin to be higher as well.
Yeah, so if she had diffuse ST elevations, then she could have what?
The MI or the heart attack.
So if she has ST elevations throughout all the leads on the EKG, most likely it's pericarditis.
Oh, okay.
But if she has a 0.07 troponin and she has ST elevations in a specific territory of the heart, and we'll go over EKGs a bit later, but if she has that picture, well, this can be an early heart attack. You might just get the troponin at the earlier side of it, and if you repeat it in 4 or 5 hours, you'll see a significant increase in her troponin.
Okay.
Does that make sense?
Yeah.
Okay, good. So, Dr. Rivero, let's say we did get a repeat troponin. It went from 0.07 to 6.0. What would you want to do?
So I think this is not like a heart problem.
But let's say we are still on maybe that this is a heart problem, and her troponin goes from 0.07 to 6.0. So that's a dramatic increase. So are you going to be more convinced that this might be a heart issue?
Yeah, this would tell me that the heart is working a lot harder to try to pump blood. And what I would do is, well, I know you mentioned like this dye that they can put in the heart and see if there's a blockage. So I would do that. And then if we find a blockage, then I would do like a catheter immediately.
Yeah, so the catheterization is kind of what we do to see how the vessels are. So we put a catheter inside one of the vessels, we snake it up to the heart, we inject dye into the coronary arteries, and we look to see if there's any blockages along the way as the dye goes into those vessels. If we see that there's a blockage and we can put a stent in there, we'll snake a stent in, we'll open it up, and now we've reintroduced blood into the area that wasn't getting blood before. So because the troponin increased dramatically from 0.07 to 6.0, we know that there's active cardiac death, and so we need to get her to the cath lab as soon as possible. So yeah, good job. High troponin usually associated with pericarditis. That is a good question. I have to think about that. I'll look it up and I'll let you guys know. I'm assuming if you have some type of cardiac injury, you can maybe have a slightly elevated troponin, but you're not going to have a dramatic elevation like you would in a heart attack. But that's a really good question. I'll take a look at it. And then troponin, high troponin equals MI as the heart starts dying faster. It can. So if you have a high troponin that's significantly elevated, there's not a lot of things that can cause that. So most likely it's an MI, and you have to get her to a cath lab as soon as possible. In patients that have kidney failure and can no longer filter out things because the kidneys aren't working, a lot of times if they have a little bit of heart injury, the troponin can be elevated, but because the troponin is cleared by the kidneys, it can maintain elevated for a lot longer than you would expect. So that's just something to keep in mind. But high troponins, you should always be thinking of a heart attack. Perfect. All right. So lastly, Dr. Dang. I gave you guys an a chest X-ray. Can you interpret what you saw in the chest X-ray for me?
So I see on the, sorry, hello, can you hear me?
Yeah, I can hear you.
Okay. In here, I see that there's a light on the right lower lung quadrant that looks cloudy, indicate there's like an infection right there. And also on top, when I see, there's one of the part that said she have the chest pain on the right lower chest as well. So that could be due to her lungs and not the heart, because that's the part like the lower lobe of the lungs. And then also she has like the prior like cough, and so that could be because of the lung problem, like the inflammation in the lungs.
Good. So when we look at chest X-rays, the easiest way for you guys right now is to look for symmetry. So the chest X-ray in general should be pretty symmetric. So the left side should look like the right side. The only difference really should be the heart. And so when you look at the lung tissue itself, if it's darker on one side, it should be darker on the other side. And when we look at this chest X-ray on the right lower side, we see that it's darker, right? So there's something there. Now, chest X-rays work because you're shooting radiation at the chest, and those X-rays are going to pass through the chest and hit the backside on basically a film, and you'll be able to, depending on how much of those X-rays reach the film, you'll be able to see how dense tissue is. So air is not very dense, and so a lot of X-rays will pass through. It'll look more black. Bone is very, very dense, and so with the bone, it looks very white. And so you'll have gradations of white and black. And so looking at that portion of the chest, it looks a little bit denser. It looks a little bit more white. So that means that it's more solid there as compared to the other side that is a little bit more airy. More X-rays are able to pass through. So if it's more dense, that means that there's something else there that's not supposed to be. And so, but it's not quite at the level of the bone. So it's most likely some type of fluid or liquid. If it's a little bit darker, you can say that it might be a mass, like a cancer, but it seems a little bit more fluffy. And we'll go over X-rays. So perfect. So Dr. James, what was your final diagnosis? All right, let's go to Dr. Juliana.
My final diagnosis was pneumonia, just because of like what we saw on the chest X-ray, in addition with like the like sound in the lungs that was in the same kind of situation with the prior infection.
Okay, good. Was there anything else that you guys were considering?
We also had pericarditis and pulmonary embolism possibly, but because we didn't have like the change in the EKG that like would signify a pulmonary embolism, we kind of crossed that one out, and there wasn't a friction rub with the heart for pericarditis.
Okay, so you said you didn't have the signs of pulmonary embolism on the EKG?
Yeah.
So what's the sign of a pulmonary embolism on EKG? What's the more typical sign?
Like an ST sigma elevation and like a rightward shift of the QRS axis. Along with what? T-wave inversion?
So you're thinking of the S3, T3, I forget what it is exactly. So that is a classic sign for pulmonary embolism, but it's not a very common sign for pulmonary embolism. It's a sign of, I believe it was right heart strain, but more commonly, what we see in pulmonary embolism is just sinus tachycardia. So if you have a patient coming in with chest pain, shortness of breath, sinus tachycardia on EKG, it can still be a pulmonary embolism. And that what you're talking about is classically seen. So if you see that on EKG, you should automatically think PE. But if you don't see it, you can't rule out PE. Does that make sense?
Yeah.
Perfect. So, Dr. Mina, you're saying vitals meet SIRS, so if we can find a source, she'd also be septic. So do you want to explain that a bit more?
Yeah, so like at the very end of resident 7's group, I know you were talking about aspiration pneumonia, So, given her age and her vulnerability, if she were to like choke on something that she was eating or drinking, and then it eventually entered her lungs, that bacterial infection could be the cause of her pneumonia and then lead to sepsis.
So yeah.
Or if she had a different sort of infection.
I didn't hear what that last part was. What?
I was saying if she had a different source of infection, then we can maybe test for bacterial cultures and then like put her on an antibiotic.
Yeah, so she needs SIRS because of her vitals and her white blood cell count. And she has a source which looks like a pneumonia. She can potentially have a different source as well. She can also have a UTI at the same time. So that's always a consideration. Now, the source of the actual pneumonia itself, whether that's community acquired versus aspiration, a lot of times we don't know, and we empirically treat for what we think is more likely. Because she has dementia, if she has trouble swallowing things, or we see that she might be an aspiration risk, meaning she's eating something and it looks like she chokes on it, well then aspiration might be more likely, and that can dictate which antibiotics we use. But for most people coming into the hospital that weren't previously hospitalized and don't have those risk factors, we usually just think community acquired, and we can treat with something like ceftriaxone or azithromycin. It really depends on what you're suspecting. So that's a good question, though. Dr. Kramer is asking, would we also still test for COVID currently as a precaution? So definitely yes. Anybody with any pulmonary symptoms, you should test for COVID, just because we really don't know what those symptoms, what the classic symptoms for COVID are, and new things are popping up all the time. I think I told a previous group that a relatively young guy came into the hospital, and all he had was a DVT. So he had a blood clot in his leg, and I think he also had a pulmonary embolism. And he had no risk factors for getting a blood clot, and found out he was COVID positive. So COVID also increases your propensity to form clots. So yeah. Dr. Dang is asking, there's a small white area around the right side of the heart, more white than on the left side. Does that mean that the heart also got affected by the infection as well? I have to take a look at the x-ray again. I don't have it pulled up. If you want, I'll take a look at it and just post this question in your stream and I'll answer it. Female symptoms portray different than white males. If you're talking about an MI, then yes. So for the person on YouTube, they're saying that they were thinking of an MI. So yeah, so if you have risk factors, you should always consider myocardial infarction, just because females and the elderly will have a different presentation a lot of times. So the symptoms that I've seen have been throat tightness. I've seen arm pain. I've seen abdominal pain as well. And so there's no one consistent symptom that will be a heart attack all the time, or there's not a symptom that you can say that if they don't have this, they don't have a heart attack. So you should always keep your suspicion high with anybody that has risk factors. So good. All right. So I think that was the end of my part of it. I can hang out for probably another 5 to 10 minutes to answer any questions you guys have. I hope that this was helpful to see how we go through the case and how we dissect all of these components of the history, and how we can use that to come up with a differential diagnosis. And if you guys have any feedback on how this went, just let me know. Someone on YouTube is asking, does her chronic kidney disease have an impact on the diagnosis or the treatment plan? So yes, it does. So her CKD in general, not so much specifically the CKD, but the AKI on top of her CKD will dictate whether or not we can do certain tests. So like I mentioned before, contrast is a big cause of kidney injury. And so if you give somebody with CKD or an acute kidney injury contrast, you can make that worse and put them into renal failure. So that can affect it. The other thing is that one of the medications that we give for a heart attack is lisinopril, because it can protect the heart and protects from remodeling of the heart. And so I know she's on lisinopril already, but if she wasn't on lisinopril, we wouldn't be able to start it because that can affect the kidney as well. So it wouldn't directly make one diagnosis more likely than the other per se, but it will affect the way that we treat the patient. So I hope that answers your question. Could I explain why her pain radiates to the right arm if she had pneumonia? Yeah, perfect. So actually, let me see. Dr. Masterson, do you want to maybe try that one?
I was also confused about that. I was thinking maybe because of her coughing, she might have some sort of muscular pain, and also she is lethargic, so that might be contributing to it.
Good. Yeah. So I actually wasn't even thinking about muscular pain. So yeah, if she pulls a muscle, she can definitely have right shoulder pain. But it says the right shoulder pain is radiating to the chest pain is radiating to the shoulder. So Dr. Crickard, can you explain what you mean by referred pain?
Yeah, so like on like the spinal cord, if there's like pressure or anything that happens to the spinal cord to cause any type of injury or even just the pressure up against it, it can cause radiated pain to a certain area, and usually that pain is going to be stabbing, and it's not going to be a dull, achy pain.
Yeah. So so when you're talking about the spinal cord, are you talking about like the nerve roots that come out of the spinal cord?
Yes.
Okay. Yeah. So the pain that she has in the right lower thorax is close to the diaphragm. So Dr. Natoli is actually saying phrenic nerve. Can you explain that a bit more, Dr. Natoli?
The phrenic nerve, from what I know, helps like move the diaphragm. Like when she's breathing, it's an important part. And so if there's any irritation with that, she'd feel pain in that area.
Yes. So so the phrenic nerve roots come from C3, 4, and 5. So those are spinal levels in the neck. And so those nerves travel down to the diaphragm and help it move. So if you have any diaphragm inflammation, it can cause referred pain to the shoulder, because the nerves that go down to the diaphragm, those same nerve roots go down to the shoulder as well. So the pain that's in the diaphragm area because of the inflammation is referred to the shoulder because it originates from the same area. So if we think of a similar phenomenon happens when somebody has surgery and they have laparoscopic surgery, because we put air inside the belly to inflate it, so we can use cameras to look inside and have space to maneuver. And so after everything's done, we take all the instruments out. There's still a little bit of air in there, and your body will eventually reabsorb it, but the air causes irritation underneath the diaphragm. And so a lot of patients will say they have right shoulder pain because of that air underneath the diaphragm. It is very irritating. Similarly, like for males that are hit in the testicles come from the abdomen. So when they're hit, it feels more like abdominal pain, not so much testicular pain. And so it's all because the origin of those structures. And so the phrenic nerve comes from those spinal roots that also innervate the shoulder. So that's why you have that referred pain to the shoulder. So I hope that clarifies things. Someone on YouTube's asking, I was wondering if next week will be set up similarly in terms of the case study and what to do in preparation. So next week is going to be a little different because you're not going to have the material. You're not going to have this case ahead of time. So you're going to have to be comfortable with thinking on the spot. And so, like for instance, for this case, you would be asking me. So I would say the patient comes in with chest pain and shortness of breath, and you would ask me, when did that chest pain start? Does it radiate? What's the quality? All that stuff, and we'll go through the case that way, and I'll guide you onto the things that were more important. So it's more like morning report and you guys solving the case together. I just wanted to get have you guys get a feel of the general case right now and how the flow works, so that next week when it's a little bit harder, you will be a little bit more comfortable. So Dr. Natoli is asking, is the phrenic nerve related to hiccups? I believe so. If I remember right, you can have a spasm, it's irritation of the phrenic nerve causing a spasm of the diaphragm, giving you hiccups. But I have to double check that to make to remember to see if I remember correctly. The physical exam showed no palpable adenopathy because URI moved down to her lungs. But are there any nodes that would signify a lower respiratory infection? Okay. So adenopathy in the cervical adenopathy, so the lungs, the lymph nodes in the neck are usually enlarged because of infection of the head and the neck, because the head and neck drain down into the heart, versus inside the lungs you're going to usually have adenopathy within the chest draining into the heart. So we don't see it out here in the neck because it's already closer to the heart, so it doesn't drain back up and go down. Same thing with the armpits. You have some lymph nodes in your armpits, and so you're not draining out to the armpits and coming back in. Now, you don't always have to have adenopathy with an infection. It only happens sometimes. So it's not a super reliable test. Like if somebody has no adenopathy, you can't say they don't have an infection. So I hope that answers your question. Will you ever be able to tell for increased confusions due to dementia or as a symptom of pneumonia? Would you then try to treat the dementia as well? So you can treat the dementia. There are medications for dementia, but they don't work particularly well. The best way to check to see for confusions because of the pneumonia is just by treating the pneumonia. If you treat the pneumonia and she gets better and she's less confused, well, then you know it's probably the pneumonia. Sometimes in the hospital, though, patients will get more confused, especially if they have dementia, but they're getting better from the pneumonia. And a lot of times that's because they're in an unfamiliar environment. And so you always have to keep that in the back of your mind as well. Yeah, of course, if you guys have any other questions, if anything didn't make sense, feel free to message me, email me. I can try to go over things a bit more. If you have any ideas of how we can make the program better, or if you make it a little bit more interactive, just let me know too. The feedback would be super helpful. If there's no more questions, I'll let you guys go, and I will see you guys next week. All right, guys, have a good day and take care and stay safe.